and we have a very senior pediatric neurology consultant, Dr. Rajni from Mania, to take you and guide Gaurav along this case on the part. So Gaurav, over to you. You start the case. Fine.
Good evening, everyone. I'm Dr. Gaurav Arora, second year DNB resident in pediatrics at Gangaram Hospital. And today I'll be presenting a case of a 5-year-old male child who is Muslim by religion, resident of Rajouri Garden in Delhi only. And the informant is father, who is a reliable source. And the date of admission is 16th of August. And the date of examination was 25th of August. So the child came with complaints of fever for 6 days, which was 10 days back. Child was afebrile for past 4 days. Abnormal behavior for past 6 days, and abnormal body movements, which were there for past 5 days, and decreased left-sided movement for past 3 days. So continuing with the history of presenting illness, the child was apparently well 10 days back when he developed fever, which initially for 2 days was low grade intermittent, responding to medication. And child was active in interfebrile phase, and it was not associated with chills or rash. From the third day of illness, the fever progressed to being high grade intermittent every fifth to sixth hourly and relieved with medication. From day 4 of illness, child developed abnormal behavior in the form of seeing people or ghosts around him and associated with high grade fever. And it was intermittent with child being responsive and alert in between the episodes. After which the child was admitted in outside hospital. On day 5, the child started having abnormal body
Gaurav,
movement.
Gaurav, I'm
Yes.
just go back on the partner. Maybe we'll go back on the. So, do you have that? We'll be describing later on. Okay, how long this abnormal behavior used to last?
So it was along with fever only. When the child had high grade fever, that time he was having this abnormal behavior. When the fever comes down, though, he was responsive and alert in between the episodes.
For minutes, for hours, or for like?
It was for minutes only, sir, like half an hour to 45 minutes.
So it
After
was
which
like,
child,
so it was like delirium.
yes, ma'am, it was like delirium.
So you should say visual hallucinations, or you can say abnormal, like people looking around ghost, and that thing you can conclude as visual hallucinations.
Yes, ma'am.
Okay.
Okay, please continue.
So on day 5, the child started having abnormal movement of body, which was associated with uprolling of eyes. It was generalized tonic-clonic movements involving both upper and lower limbs, and it was not associated with passage of urine or stools, and it lasted for about 2 to 3 minutes, after which the child was drowsy for 5 to 10 minutes. After which there was a progressive dip in the level of consciousness of the child. Child continuously had shaking movements involving both limbs, which were occurring even at rest. The level of consciousness of child was like child was awake but was not aware according to the parents. And
How
child,
many seizures happened? Day 5, he started to have seizures.
yes, ma'am.
So in numbers, could you ask
There
the
was, ma'am, one episode of seizure only, in which uprolling of eyes or generalized tonic-clonic movements were there.
this
After which
line
there was,
actually suggests that he had multiple episodes, abnormal movements. So you should mention that one single episode of seizure or
yes,
abnormal
ma'am.
movements as you described. And that happened. And after that, there was a alteration of sensorium.
Yes, ma'am.
Hmm. Okay, continue, please.
The child was awake but was not aware, according to parents. The child became afebrile from day 6, and on day 7, the child had decreased movement of the left side of the body, which reached its maximum within a day and was equal in both upper and lower limbs. And the site of onset was not known, was unknown. It started with lower limb or upper limb, was not known.
The shaking movement should be further explained that what kind of movement it is. It is not giving any visual impression, whether it was a twisting, turning movement. Basically, whenever we want to explain about the abnormal movements, your history should mention whether it was chorea, whether it was dystonia,
Same.
whether it was so that kind of the particular term keywords you have to mention here. So what was that abnormal movement of both lower limbs?
The movements were involving both the limbs, and they were to and fro kind of movements occurring around the axis, and which were occurring even at rest, and was same during body movement matlab while he was doing something or while he was on rest, it was same.
Okay.
So most likely it was
What
tremors.
happened during sleep?
Sorry, huh?
What happened during sleep? Sleep.
Sleep. I didn't ask that.
So whenever you ask abnormal movements, so there are some set of points. Dr. Praveen, should I discuss it here or we can discuss it later?
Anyway, I mean, we can let him know also here also, because that will be anyhow we have to guide him on the partner.
Okay. So see,
Which we do.
whenever we discuss about abnormal movement, first is phenomenology. As we discuss in seizures, it is semiology. In abnormal movements, it is phenomenology. So you have to tell, like you told, that was nice, that to and fro movement around the axis, that gave an impression that it was tremor. So
Yes, ma'am.
rather writing than shaking movement, we should write all these words. Then you have to ask whether it was continuous and what happened during sleep and in drowsy state.
Okay.
And since you already told that there was a dip in level of consciousness, probably child do not have a sleep-wake cycle.
Yes,
Here,
ma'am.
as you have written that there is a progressive altered sensorium. Altered sensorium is a better word rather than writing this level of consciousness because it's a total a medical term. No? Here we use a generic or a literal words. So alteration of sensorium. And here child was, you can have some idea here about the sleep and wake cycle, whether
Yes,
child was
ma'am.
having sleep or wake cycle or not. So if what happened during awake state, what happened during sleep state, and was there increase with the fever, or basically you have to tell me the course, it was waxing waning or it was continual, that kind of thing. Other than that, was it associated with increased tone? Basically, if a child has altered sensorium, the child has tremors. Mostly these children, they have increased tone and then these tremors happen. So here at the same time, you can tell whether the child has abnormal tone or not, or what was the overall posture of the child. So that,
Um, yes, ma'am.
like, I think that is the next day 7 you have written about the posture, that there was some paucity of left side of the movement.
Yes, ma'am. The left side of the body was in hemiplegic kind of posture. Matlab, upper limb was flexed in
Hmm.
elbow and wrist joint, and the lower limb was extended at knee and ankle joint.
And these shaking movements during that time, was there
Um, was decreased in left side and were prominent in right side of the body.
that shaking movements also?
Yes, ma'am.
So that also you should mention. That you have mentioned both limbs means lower limbs or upper limbs.
Where, ma'am? Equal in both upper and lower.
These tremors were present in both lower limbs or upper
Yes,
limbs.
ma'am. Both upper and lower limbs.
So here tone becomes very important. Was it decentered posturing with tremors? Because Dr. Praveen, can you suggest anything here if I'm asking?
That's fine. I think because as Dr. Rajni asked, na, ki, what happens to, if you say this is tremors, what happens to tremors in sleep?
Mhm.
Do they
Yes.
persist or do they, I mean, stop?
So the sensorium was not good. Matlab, awake and sleep cycle was not.
So he was not indicating his basic needs. Whenever you write altered sensorium, so first point you should write, he is not indicating basic needs. He is not aware of his bowel bladder. Second thing you write, he is not interacting with the family, and then sleep wake cycle. So we know that he is almost in a semi coma or coma kind of state. And then these movements were there. And then you have to write when somebody holds, what happens on passive stimulation or something of abnormal movements.
Yes,
So
ma'am.
what was there? If attendant used to hold it, was it stopping, not stopping?
It was stopping. Matlab, attender was able to control them on resisted. Matlab, it was
It was
stopping.
continuously happening, and when they were trying to hold it, it was
It
stopping.
was stopping. Yes, ma'am.
All these points should be there in altered
Yes,
sensorium
ma'am.
and in abnormal movements. These points were little lacking. Okay.
Okay.
Then there was a decrease in movement, day 7.
So most of the tremors, Gaurav, they stop in sleep now. Fine. So that's why you, I mean, that gives you a kind of like idea. This is what kind of movement disorder he has on the part.
Okay.
Okay. He can go ahead now.
Yes. The negative history, there was no history of squint, drooling of saliva, or deviation of angle of mouth. There was no history of any bowel or bladder disturbances. There was no history of headache or vomiting. There was no history of ear discharge, recurrent cough, cold, or loose stools. There was no history of recent vaccination, travel, or TB contact.
So based on the history, what I mean, clinical diagnosis you have to ask all these negative history, Gautam?
So, I was asking about for deficits like squint, drooling, or saliva, deviation of angulum to ask about cranial nerve involvement in the child, and for bladder and bowel dysfunction to ask about autonomic dysfunction, and headache and vomiting to rule out meningitis or increased IAP, matlab ICP, intracranial pressure.
Okay.
And from the history, we can get there was fever with altered sensorium and seizures. So mostly cortex would be involved. So motor and sensory examination could not be elicited. Sensory history could not be elicited, and like, angel. By asking ear discharge, recurrent cough, cold, loose stools, and recent vaccination travel, it is to rule out the cause of the disease.
Okay.
So Gaurav, it's nice that you have clubbed in three parts. So whenever we take the negative history, one thing is the total neuro axis you should cover. So you have covered cranial nerve features like squint, rolling of saliva, deviation of angle of mouth. But I think in first go, when you explained your altered sensorium, you have to tell us whether sleep wake cycle was present or not. Child was having some alteration like he was sleeping, waking, or he was constantly like vegetative.
Yes, ma'am. He was
No, what
mostly
was there?
vegetative only.
So he was not interacting. He was not telling
Yes, ma'am.
any, not indicating any needs to the parents.
Yes, ma'am. He was non-responsive.
Non-responsive.
Yes, ma'am.
And then you have to tell about abnormal movements also that we have already discussed. And sensory examination, you cannot say that it could not be elicited because you can say that child, whenever what happened during the wet pants, suppose the child is lying soiled, was he crying? Was he reacting? What happens during touch and pain? Was he moving? Was he not moving? That will give you a somehow idea of the EMV part, the motor part. So
Yes, ma'am.
bio history, we know that the child is somewhere in coma. So you have to tell that on okay, that will come in history. In examination, what happens when you touch or speak. But some idea should be there that whenever the child was wet, how does it indicate? And when he was touched or dressed by the parents, what was the reaction of the child? So that
Yes,
will give some idea of the sensory examination. Headache vomiting is for ICP. So that was not there in the child.
no, ma'am. Headache in initial days, headache complaints of headache vomiting were not there.
So here you can add a posture also. That what was the posture of the child? Did the child had extensive posturing or he became more stiff when he was stimulated? So that will show that decerebrate posture was there or not.
Yes, ma'am.
And then negative history, you have taken ear discharge, cough, cold, loose stool, and recent vaccination travel. Negative history is all right. Rash, one thing I think you should write about the rash. Was there
Rash I mentioned during fever part
okay.
only.
Okay.
Rash and
He had
chills.
rash or he did not have rash?
No, did not have rash, ma'am.
Okay, fine.
So there was no significant past history. Treatment history. On third day of illness, parents went to the nearby practitioner where when the fever spike increased, they went to a practitioner where he was treated as enteric fever. And on day 4 of illness, when he had delirium, the child was admitted outside where multiple IV drugs and antitubercular drugs were started. And CT brain was also done, which was normal according to the parents. And since the child had worsening in sensorium and new onset left side weakness, so was brought to SDRH on day 10 of illness.
It's quite
And
strange, na? The ATT on day 4 of the illness, right?
Yeah.
Why do you have anything, something to suggest?
no, the
Possibly
CT was
midnight.
also normal. There was.
Okay.
Antenatal history, mother age at conception was 31.5 years, conceived spontaneously. Rest antenatal history was not significant. Natal history, it is late preterm child, normal, born by normal delivery, who cried immediately at birth and with a birth weight of 3.1 kgs and no NICU stay. Family history, third child born to a third degree consanguineous marriage with no significant family history or no history of seizures or TB in family.
What is third degree consanguineous marriage, Gaurav?
So, child born to uh, sisters, children. मतलब father, he was born to his father's daughter's brother. How do I explain?
So maybe you can just put the in the simpler terms, na, ki father had married his
Married the
His own cousin
cousin.
sister, cousin
So it will be second degree, no?
cousin sister's daughter, मतलब.
Cousin sister's daughter.
so mean that you should have the answer with you when you mention this, na, third degree consanguineous marriage, because that
There
tells you
should be
that.
there should be a flow chart also where it mentions that this kind of relationship was there. Basically, you have to extend one more generation up
So
in the pedigree.
it
Yes,
should
ma'am.
be, it should be clean to you to say this was a third degree partner. Okay.
Yes.
Mm.
Nutritional history, non-vegetarian by diet, and the total calorie and protein intake were adequate for the child before the illness. Immunization history, it was immunized till date according to the national immunization schedule. And developmental history, there was no history of development delay, and the development was appropriate for age. Socioeconomic history, there's 7 people.
Come early after birth. Immunization will be little. Development should come early. After birth only, maybe next section you can say development. And when you say immunization, you have to write about additional vaccines, whether did he receive and additional polio vaccines did he receive. Just go to that immunization slide. Immunized till date according to national immunization schedule. So sometimes what happens when you take this, you have to ask if it had taken all the government vaccines, then mostly they give MR. They don't give mumps.
Yes,
So
ma'am.
when you know that you're dealing with some case of viral encephalitis or some encephalitis, you have to in detail ask this history that it was through a government institute, what it was given regularly, no additional vaccines were taken. So instantly we know that mumps probably was not given to. So you can put that as your etiology, probability etiology maybe. And additional polio vaccines were taken or not. Okay, because in national immunization schedule, varicella is not covered. They do not cover hepatitis A, they do not cover
Yes,
influenza.
ma'am.
So
Only government provided vaccines were given.
okay. And here pneumococcal also you should mention. If immunization scheduled by the government, not all, suppose this patient is not from,
Area.
yeah. So you have to write that he did receive pneumococcal vaccine. We can proceed further.
Sorry. Socioeconomic history, there's 7 people residing in the house with and family belonging to a upper middle class according to the modified Kupuswamy scale. This was a video on day 5 when he was admitted in outside hospital. The child eyes are open and there are shaking movements all over the body.
Can you run the video again, Gaurav, for all of us?
Yes.
So here you have to mention that the child had increased tone of the body of all the limbs and when extended, whether it was possible. Basically, at this point in time, if somebody would have done some flexion extension, whenever you come, your tone should come in the presenting illness always. Whenever there is fever, altered sensorium, seizure, abnormal movements, so there has to be some line increased tone, not increasing tone. That's a part of
Yes.
focal development. So if you tell increase in tone, what happens during passive stimulation? So you don't have to tell that I did it. You have to tell whenever the parents wanted to stimulate it, it showed. So we have some idea whether it is spasticity or rigidity. Okay, so these are
Yes,
tremors, definitely, as you said. So tremors with increased tone, and child is constantly having a vacant stare. Eyes are open, and with a vacant stare, he is looking.
yes, ma'am.
Okay.
So to summarize, we have a 5-year-old male child born to a third-degree consanguineous marriage with uneventful antenatal natal history, normal development milestones, and complaints of fever for 6 days, 10 days back, and altered behavior and one seizure episode 6 days back, with tremors for 5 days and left-sided hemiparesis for past 3 days. So we would like
Tremors,
to consider.
generalized tremors. Once, can we go back?
Yes,
Generalized tremors and left-sided hemiparesis. That was. Can we see the video once again? Was it left-sided hemiparesis?
ma'am.
Left side was flexed, and both the legs were
On
fine.
day 7, left-sided hemiparesis was noticed by parents,
It
and
was
this was
not
on day
showing
5.
that. Okay, okay, fine, fine.
Yes, ma'am.
Hmm.
So we would like to consider child is suffering from acute onset progressive encephalitis with movement disorder and focal neurological deficit, probably of infectious or autoimmune etiology.
Where will you localize?
We will localize could be in cortex also, but there are movement disorder, so there are more chances of subcortical region of basal ganglia.
Hmm.
So and focal neurological deficits could always there in subcortical region.
Subcortical.
Subcortical and
If you say
uh,
hemiparesis, where do you say localization?
brain stem.
Brainstem,
I'm
somewhere internal capsule, something you have.
internal capsule. Yes, ma'am.
So you have basal ganglia, you have internal capsule, you have cortex, and what else?
There were no cranial nerves.
Child is also encephalopathic. Okay,
Yes, ma'am.
he has no sleep-wake cycle. So these lesions are mostly in thalamus because there is a reticular activating system in
Yes, ma'am.
thalamus and it covers brainstem.
Yes, ma'am.
By these features, you know that somewhere thalamus might also have been affected. So it is deep gray matter also which is affected.
Yes.
Okay.
How is the hemiplegia of cortex differs from the internal capsule or the kind of like brainstem, Gaurav?
In the internal capsule, we have dense hemiplegia.
We start with
In
the cortex. How does the cortex hemiplegia manifest? Cortical hemiplegia, what all symptoms it will have?
in cortex, there would be altered sensorium, seizures, and with if hemiplegia is there, depending on the location, like if it is in the medial part, then we'll have more weakness in the lower limb, and if it is only lateral part, then we have more weakness in the upper limb than the lower limb.
Okay.
And in internal capsule, we will have dense hemiplegia.
What else you get in the cortical hemiplegia? What about the vision?
There could be visual disturbances also, sir.
So important thing about the cortical. What about the speech part?
Dysarthria could be there, sir. Other involvement will be.
So starting from the head, you have the alteration in sensorium, as Dr. Rajni is telling number of times that you will have alteration in sensorium. Then what you have in the basically that the speech is also lost if it is a dominant kind of like a hemisphere involved on the part. And above that, you'll have the vision loss also. So you can think about, you can imagine about your head only. Na? So what will happen to the head if it is a kind of cortical lesion? You'll have alteration in sensorium, with vision can get affected. You lose your kind of speech part, and then definitely you've got the hemiplegia part. Okay, and then internal capsule, brainstem.
In internal capsules, we have dense hemiplegia in which both upper and lower limb are involved equally. And in the brain, in internal capsule, we could have this only. And in brainstem region, cranial nerves would also be involved. Contralateral hemiparesis would be there.
Okay, so internal capsule may not have the other signs like the speech, the,
Yes.
the higher mental function, okay, and the vision part in it.
Mhm.
So what do you find in this case?
In this case, we have involvement of higher mental function also, and altered sensorium also, along with the matlab hemiparesis was equal in both upper and lower limbs. So it is, matlab, we are more going towards subcortex region only in internal capsule, along with the mild cortical involvement, and with movement disorders and focal neurological deficit. In movement disorders are there in basal ganglia region. So
If it,
more
there is a ipsilateral canal of palsy and a hemiparesis, suppose of one side only, left side. So where will the lesion be?
cortical region, corticobulbar tracts.
Facial palsy and ipsilateral hemiplegia.
Cortical region, cortex will be involved, in which corticobulbar tracts will be involved and corticospinal tracts will be involved. So ipsilateral weakness could be there.
Is above the brainstem, as we say that cortical lesion involving the internal capsule, and that is above
Internal
the.
capsule.
If it is at the brainstem or below the brainstem, then contralateral.
Yes.
Lateral canal of palsy will be there. Because whenever you deal with these kind of cases, no, this basic science, anatomy, neuroanatomy questions will come up.
Yes, ma'am.
Okay.
How will you explain tremors in this case, Gaurav? You said that he has a predominant tremors also on the part.
So basal ganglia involvement could explain, or tremors.
Okay.
Tremors could also be there, वैसे तो in red nucleus involvement in
Down
midbrain,
the brainstem area.
brainstem area.
Okay. And
Yeah,
then
everything is indicating the brainstem part, brainstem and basal ganglia part.
Yes, sir.
so if you have to come down on the part, so can you have one area where you can have alteration in sensorium also, hemiplegia also, and tremors also? So if of all the locations which you said causing hemiplegia, what can be the predominant thing which can cause alteration in sensorium also? You can have the hemiplegia also and the tremors also, which are the predominant signs you said, na?
Yes, yes, sir. So could be there in brainstem region also, because red nucleus is there, and cerebral peduncles are going in cortical spinal tracts could be involved there along with red nucleus.
Basically, midbrain. You want to say
Midbrain.
midbrain as a part of brainstem. Okay.
Yeah.
And what other area?
Midbrain and what's up called, matlab, basal ganglia or internal capsule,
You
subcortex.
come down from basal ganglia. You already have come down to brainstem area. Don't go back on the basal ganglia again on the part. Na? So you're right on the brainstem. So as
Yes,
Dr. Reddy is also saying about the midbrain part,
midbrain.
already have gone down to the nearest location.
Yes, sir.
Other thing is thalamus. Thalamus with internal capsule involvement can also cause this.
Yes.
So midbrain is rightly said, because you have to zero down to these tremors, altered sensorium, that by history and by the simple video, you know that these are the areas which are affected.
Yes, ma'am.
What is progressive encephalitis? Do you have anything like non-progressive encephalitis or?
We can have static encephalitis. Matlab, it's just to define the course of disease.
But is it term like progressive encephalitis also? I'm
No,
just asking. I'm not coming.
I don't think so, sir.
I think it's wise to avoid the terms which are not there in your textbook part also on the one.
Acute onset progressive. No, encephalitis you cannot tell here. Okay, you've written encephalitis. So acute meningoencephalitis. Did you mention about meningeal sign? Did we come up? Achha, okay, that will come in examination. This is history only.
Still,
Acute
but other than
onset
Yeah,
or
sorry.
acute febrile encephalopathy is a simple term if you don't know anything. Acute febrile encephalopathy with a movement disorder and focal neurological deficit.
Okay.
what we call them as acute encephalitis syndrome kind of part. No?
Yes. Or yeah, AES is a standard term. You can write acute encephalitic syndrome.
Yes, ma'am. We used that in last after examination. Yes.
Okay.
Okay,
So
got it.
course in our hospital. Yes. Child was admitted in PICU in view of poor sensorium and was kept on room air, and multiple IV drugs were given. And as the child condition improved, the tremors decreased and sensorium was improving. The child was shifted to ward on day 3 of admission. and on general examination, which was done on 25th of August, child was lying on bed, was irritable but consolable, interacting with surroundings, playing with phone and interacting with mother, and was not very cooperative for examination. The behavior was not appropriate for the situation as there was evidence of aggressive behavior while approaching the child.
No, go back to that. That's
Yes.
mental state examination, I think so, or a general thing. This is a general overview you're writing. Like
Overview. Yes, ma'am. General
irritable.
overview of child.
So here you have to write about the posture also. Was he sitting? Was he? You just wrote lying on the bed.
Mm,
Was
okay.
he sit during that time? Because playing on the
So,
mobile, so you told.
I mean, he
Okay.
was sitting with support only when the bed head end was elevated.
So
That time he was sitting with support.
interacting with some with surrounding, interacting with the parents, not surrounding, interacting with
Parents.
meaningfully or not meaningfully, like speech was there or not. That will give a
Yes,
brief idea and a visual impression.
yes, ma'am.
Child was lying
That
on the
will
bed.
cover
He was
make
able to
in
sit.
hand.
He was making some minimal eye contact or a verbal contact to the parent, but he was irritable and not cooperative for examination by a stranger. And
Yes.
behavior was not appropriate is a very general term. At your part, when you're examining, the behavior, you have to write the whether it was aggressive or that not appropriate for the situation is not the right thing.
Okay, ma'am.
Okay, next.
Vitals, temperature was 98.4 Fahrenheit and the peripheries were warm and pink. Heart rate was 118 beats per minute. Respiratory rate was 34 breaths per minute and BP was 98 by 64, measured in right upper arm. The saturation was 99% at room air and the CFTs were 2 seconds. On head to toe examination, mild pallor was there. Ictus cyanosis, clubbing edema was not there. And the rest of the head to toe examination was normal only. The, though there was no dysmorphism on face and there was no discharge from
Is
ears.
it something about the build of the child? He was a thin built child, or something should be there at the upfront opening statement in the general examination. Where you
Yes,
written
ma'am.
he is lying or not. That build should also come. Thin built, obese.
It was thin only, ma'am.
You
And
are
that is not
writing that
written.
is to have a visual impression that what is happening. Though in bedside examination, examiner can always look to the child and listen to your history.
Yes,
But then
ma'am.
here we should have some idea whether it was a thin built cachectic child or obese or that.
Sure, ma'am. Yes.
Mm.
Anthropometric. The weight of the child was 18 kgs and the expected weight was 18.3 kgs and height was 110 centimeters and expected was 108 centimeters. BMI was 18, expected 18.6. As per WHO charts, weight for hygiene, height for each one in normal range. CNS examination, high mental function. The child was awake, irritable but consolable, was oriented, and language. There was spontaneous conversation speech was not there. Comprehension was normal. Speech was non-fluent with dysarthria, a slow and slurred speech with preserved skills of naming and reading.
Oriented to time, place, person, you have to write.
Yes, ma'am.
Well, consolable, oriented to whether it was there or not, time, place, and person.
Yes.
How did you check for time, Gaurav?
Day, night by asking if is it day outside, day,
Just a
night.
5-year-old child, will he be telling about day, night? So here, oriented in a 5-year-old child will be very difficult to defend. So awake, irritable, but not conceivable. Here, mostly in examination in a child who is less than 5 years or less than 7 years is what you observe. What does he indicate or communicate to the caregivers? Okay,
Mm.
to the mother itself, because the behavior will change towards you also. So he was interacting
Yes,
with the
ma'am.
mother. He was making gestural communications as well as was speaking something to the mother and was following the commands.
Yes,
Okay.
ma'am.
So communication by the eyes, communication by speech, and command following. So here it should come. This oriented word will not come here.
Okay.
And how did you check for skills of naming and reading 5-year-old child?
Ma'am, by asking him what is this, it's pen, and asking him to read something from phone, he was using his phone to.
5-year-old child will not read anything. So I think you should be pretty sure when you say these words.
The same thing. I mean, you can't have something from the phone. You have to tell that what did you give to him and what did he write on the part. You can always have your own set of questions for these things because they're very standard kind of numerical examination partner. So knowing that
Yes, sir.
I gave my pen, I gave my state, and I gave my phone, and he could name all those things. I showed my paper and he could read the part. So it should be very clear so that the examiner knows that you have really done the test on the part. So that is the basic thing.
By asking him, by writing touch your nose and showing him, and after that, if he follows, that will be
What
standard.
we are what we are saying that we are not asking you what he does or how you tested for the partner if he follows on the part. So you must be very clear that what you did in the examination, what all test you offered to him, and what he did in that offered test. Is it
Yes, sir.
clear? Yeah.
Yes, sir. In cranial nerve examination, cranial nerve 1 was not examined. Cranial nerve 2, gross vision was present, but visual acuity, color vision, field of vision could not be assessed.
But
Fundus was normal.
why not one you could do?
So he was not very cooperative for examination.
But he was naming. Now you said he was naming.
From phone, that was little easy.
Okay.
Alignment of the eyes were normal. There was no ptosis or extraocular movements of full. And nystagmus was not there. Pupils were 3 mm bilaterally equal and reactive. And there was direct and indirect light reflex was normal with the accommodation reflex normal. Muscle of mastication was normal. There was no jaw deviation and sensation could not be examined. Cranial nerve 7 was normal. Cranial nerve 8 cochlear component was normal. He was able to hear. And cranial nerve 10 movement of palate and uvula was normal. Cranial nerve 11 sternocleidomastoid and trapezial bulb were normal. There was no drooping. And tongue, there was no deviation or fasciculation seen.
How do you look for winging in this case?
So by making him bend forwards and applying pressure on his hand, it was
Tell us
tough.
again. Tell us again what do you do for the winging?
So we ask the patient to apply, forcefully, give a force to an
What
object
did you do? What do you do in this child to say
by
that?
asking him to give a force into my hand and seeing on his back
Where did you keep your hand?
in front of him, sir.
Where? But in front of him can be here also, like this or like this.
Like this only, sir.
It's very clear because this is very. I mean, this is not a common test which you can do in a child who has been lying on the partner, having the hemiplegia also. You said on the partner, correct? On the part, you already have saying the child has got the hemiplegia part, and then you are testing for the winging, and you're saying the child is not having the winging part. You should be very clearly you have really done the test on the part. Was he standing?
No, sir, he was not standing.
So winging can be checked when you keep your hands forward like this. Okay. He has to keep.
Yes, sir.
Even if he gives a pressure on the bed, it will be not in a proper angle. The serratus anterior will not be activated and you cannot comment on winging in that posture. So don't invite a lot of other questions. You can just write the muscle bulk was normal. Sternocleidomastoid and trapezius.
Yes,
Yeah.
sir.
A lot of us we understand that a lot of these tests may not be may not be doable in a pediatric patient, especially when he is not in a good sensorium on the part. So we understand that part.
Yes. So on motor examination, the bulk was normal. Tone, there was left-sided hypotonia with left upper limb, elbow, wrist, and wrist flexed and pronated, and lower limb extended in equinus position, extended at knee and ankle joint. The power of right upper limb was 5/5, and lower limb was 5/5, and left-sided was 3/5 in upper and lower limbs. Deep tendon reflexes. Knee jerk was elicited in both the limbs, upper limb, in both the lower limbs, and bicep and triceps were also there. Superficial reflexes were there, and planters were withdrawal. and abnormal movements and resting tremors were seen.
So where you have to write resting tremors, where one hand, both hand, deficit
Both
wala
hands.
hand.
Yes, ma'am.
And again, when you write tremors, when you try to stop it, whether it was stopping also on passive suppression, was it what was happening?
Yes, ma'am.
Okay. And tremors, what happened on intention? Whenever you mention tremors, what happened on intention also?
Intention.
Like when you give the pain, what happened when he reached to that object?
Yes, ma'am.
So
So
what
why?
was
Yeah, sorry, Dr. Rajni, please. Yeah.
what was there during that time? I mean, just give some idea. Was
Ma'am,
it
it
a
was same only during resting position also, and when he was making movements of his hand or trying to hold his phone.
and it was there in both the upper limbs, lower limbs as before.
Yes, ma'am. But left sided they were decreased, or right sided it was very prominent.
With
Tremors
that
was there.
tremors also, he was holding the mobile and he was able to play or do the work.
Yes, ma'am. But it was decreased. Not that I have video also for this. Can I show it, ma'am?
Yeah.
Hmm. So he's got tremors with the when he's moving the hands also.
Yes, ma'am. Yes, sir.
This doesn't look like that same tremor. This is mostly because of hypotonia. The child muscles are hypotonic, and that is why this is not typical like dysarthria of cerebellum. Even when
It is
muscles are hypotonic, you can feel some kind of shakiness.
sticky movements.
These are not the abnormal movements or tremors. It was there at rest also. No? Can we see a video on rest?
No, ma'am. That video is not there. It's only this video is there.
Can we play it once again?
Yes, ma'am.
This was the right hand.
Yes, ma'am. Left hand power was less, ma'am. It was 3/5 only.
It was a very brief video to make any comment. Whenever you prepare for a case, prepare a little longer video.
Sure, ma'am.
Okay, you
Gaurav,
continue.
yeah, Gaurav, as Dr. Rajni is saying, this is not a tremor of the cerebellum, na? So
Yes.
why? What do you find in this video? This not supporting cerebellar tremors kind of thing,
So there is no dysmetry or pass pointing
which you say. And
that should
more about the
be
tremors.
there.
What happens to tremors in cerebral disorders? What kind of tremor you get
Intentional tremors are there in cerebellum, which are increased during activities.
during activity or no? Or during reaching the
Uh,
target?
Target.
That is an intention tremor on the partner. When
Yes.
you attempt to reach the target, your tremors increases on the part, which you're not
Yes.
finding in this case. What is physiological tremors? What is postural tremor? What is physiological tremors?
Uh, don't.
Like what happens basically in old age, or maybe when you're anxious on the partner in a way. So when
With
you
stress, anxiety.
Stress,
possibly
anxiety, anger, all that can lead to tremors. Your
It
emotional
also.
state can lead to tremors. With
that like
subside when you're out of that emotional state.
that like a postural tremor. So whenever you maintain a posture, you can get the tremors on the part. Right. One is intention tremor, which you just mentioned about the partner, and other is the resting tremors. Fine. So you mentioned in the beginning that the child had the resting tremors also.
Resting tremors.
The postural tremors or the physiological tremors can be physiological, as the name says, but resting tremors are always pathological. What kind of tremors you get in Parkinsonism?
The resting tremors are there.
And what kind of tremors you get in the brainstem lesions? We're talking about the brainstem partner.
Uh, Coarse resting tremors could be there in brainstem also.
What is
Why,
home state?
why the child on NG? This feeding tube is there. You did not mention that in examination.
That's
By your side, palate, uvula, everything, cranial nerve, 9, everything is normal. Why is the child on NG feed? Sensorium wise, he is just irritable. Everything is okay.
No, it was removed after this
No,
only.
no. After your examination, it was removed. When you said everything is
But that's very pertinent. Now you must mention somewhere during the course that he was on the feeding tube part also. That's very important.
When you are
Yes,
showing the
yes,
video examination, you have to write. You have to give
yes, yes, ma'am.
the child is on NG feed and why on NG feed. By your examination, I could just make out that child has recovered of everything, and he just has some mild behavior issues other than that, and little hypotonia that I could make out.
Yes, ma'am.
Okay.
Okay, God.
So this response to touch and pain was present in sensory examination. There was no cerebellar or meningeal signs. For abdomen examination was normal, and there was no significant finding in CNS or respiratory examination.
What about coordination? Examination for coordination? Your case is mainly based on abnormal movements, no? So you should be master in theory and examination for abnormal movements. Okay. So when you speak about cerebellum, before that you have to tell about examination for coordination. So in that, what all maneuvers do you do? For coordination?
Yeah. How do you check for coordination, Gaurav? Upper limb coordination, lower limb coordination, or those things?
So like
How do you check for resting tremors?
so, ma'am, if they are present during rest time only.
No, the child is sitting idle and keeping his hand like this here or where, at what posture?
I mean,
So tell him to extend the hand and with the finger little loosened, and then you'll see whether tremors are there or not. Okay. So these are resting tremors, and then you'll tell that reach some point, and then you'll see intention tremor is there or not. This is a tremor examination is also a part of coordination. And then what else you can do? A child who's
gait, gait.
can write, you'll tell him to make the circle, this Archimedes spiral. Child who can write and hold, you can tell him that draw this pattern. So then you can see the loops, how that loops are forming. If not, then you can tell him to do some repetitive task. Basically, a single maneuver where you want to do it repeatedly. So you can tell him to do like this, like this. Whether see, child is small. You can always say, I tried to do this, child did not cooperate. That disclaimer is always there, but you should try to check whether, because you have to explain that how can you localize this abnormal movement? It is just because of hypotonia, or it is cerebellum, or it is extrapyramidal. We should have some insight here.
Yes, ma'am.
And now on therapy, child has improved a lot. So we might not be able to typically localize, but then you have to rule out. Like you have said, there is no cerebellar sign. Okay. So rather than saying no cerebellar sign, you can tell that there is no tension tremor, there is no hypotonia, there is no nystagmus, and there was no dysmetria.
Yes, ma'am.
Okay.
That
Sure.
also helps you in the coordination part, the limb coordination. Once you mention about the cerebellar signs, you can also put them into the coordination test.
Yes, sir.
Okay.
So to summarize, we have a child with acute encephalitis syndrome who on examination is irritable but consolable with speech dysarthria with left-sided hemiplegia with tremors and most possibly localizing to a subcortical or brainstem region.
So is irritable, one second, can we go back?
Yes, ma'am.
Is irritable, no, you have to write awake and aware. Child was awake, aware, irritable, crying. Consolable we use for crying. Crying, consolable, not consolable. Irritable to the parents, irritable to you. Child was irritable when some stranger or
Danger.
examiner comes, but his behavior was okay with the parents. Okay, that should come there also, and here also it can say consolable is not for irritability, it is for crying.
Crying.
Suppose
Yes,
he
ma'am.
was crying or making some gestures. With speech dysarthria, you have to mention it was cerebellar or it was extrapyramidal. Basically, you have to localize it was cerebellum or extrapyramidal. So, what kind of speech did he had? We have no videos for that speech.
No, ma'am. Videos are not there.
For mental state
Very,
examination speech, you should have made a video.
yes, ma'am.
Have given a clear idea to the other your fellow attendees also and to us also.
Yes, ma'am.
So what kind of speech was there? How will you tell that speech?
He was having a very slow and slurred type of speech. Like if I ask him ki, what is his favorite food, so he said with a pause like chole bhature. Matlab, it was non-fluent, broken, and it was slow, slurred kind of speech.
Okay. With left hemiplegia, no, left hemiparesis. You
Paresis,
already
yes.
told it is river 5. Left hemiparesis with tremors, with no cranial nerve palsy. Whenever you write mental state examination, with speech, with no cranial nerve palsy, with left hemiparesis, and with generalized tremors or tremors to what part that you have to tell. Okay,
Yes,
so cranial nerve, if there is no cranial nerve palsy or palsy, both things should be mentioned here.
should be mentioned. Yes, ma'am.
Basically, you should be covering whole neuraxis when you speak about examination and the final summary.
Yes, ma'am.
So localizing only to the subcortical structure.
Subcortical brainstem.
Subcortical is many things, no? So subcortical will even cover deep gray matter. So you have to
Yes,
write initially we discussed that it was cortical because he had seizures, altered sensorium.
Yes.
So here you have to, the child has improved a lot with therapy that we could know. But
yes,
then
ma'am.
at that point, you could just cannot tell about this. You have to keep your prior history also.
Yes, ma'am.
Okay, so cortical, subcortical region, and midbrain mostly in the
Miss
brain.
brainstem
Okay,
area.
did you comment anything on respiration? It was okay.
Yeah, respiration was okay, ma'am.
Why am I asking about respiration?
Brainstem region is
Yeah.
involvement.
Was it hyperventilating, ataxic breathing, or that kind of breathing?
Yes, ma'am.
So it is cortex plus basal ganglia and plus brainstem.
Midbrain. Yes, ma'am.
Okay. Next.
Yeah.
So, final diagnosis acute encephalitis syndrome with the most probable etiology being infectious, which could be viral, like Japanese encephalitis or HSV, or bacterial like tuberculosis, rickettsia, listeria, or malaria, or it could be autoimmune cause like ADEM.
Listeria, why listeria?
Hmm.
In brainstem region, there is involvement of listeria.
We are talking about history and examination. So here we have not confirmed by our by our investigations also. Is it a common etiology, this listeria? In my so many years of neurology
Yes,
practice, I
ma'am.
have seen listeria.
Not
Dr.
in,
would agree. It is more in the literature rather than we see in our country.
And that too in this age group also, no, partner.
Yeah, in this age group
yes,
also.
ma'am. Yes, sir. It's
More
more
than
common in adults.
Did you tell
Not
about
common in the
white in the negative history at start? Did you mention
animal
that?
bite.
Yeah,
No,
dog bite.
ma'am. I didn't mention it.
Why am I
Yes, ma'am.
asking that?
Rabies could
Yeah.
cause it.
So favorite area of rabies is brainstem. So that dog bite should come over there. Here you can put a, though you cannot put as a differential, but you should keep that as a mind in your mind. Listeria should go out. Listeria should not come. The
Yes.
rest, I think so. I would agree to that. Not in the, okay.
Can I proceed, sir? To
Yeah, yeah.
Okay.
So the basic workup was done in which hemoglobin was 15. This was done on the day of exam admission only.
Mhm.
The hemoglobin was 15 with TLC count of 9,000 and the neutrophil 65% and lymphocyte 30% with platelet count of 4.5 lakhs and the RBS was 133. The LFTs and RFTs were normal with the CRP and prochyl, that is sepsis marker, was negative. Culture was sterile and respiratory PCR biofire was also sent, which was negative, and malaria antigen was also negative.
But he had no complaints, no respiratory complaints at the start.
Yes, yes, ma'am. We check it. We did it to rule out influenza
Okay,
or the
fine,
post-infectious.
fine.
Yes, ma'am. After which CSF study was done, uh, in which the appearance was clear. The cell count were 9, that is 100% lymphocytes. Protein was 20, and glucose was 81. TB expert was negative, routine culture was negative, CSF PCR biofire was also negative, and autoimmune panel was also sent, which came out to be negative with negative NMO and MOG antibodies. And this is JE PCR and CSF only, which was not detected.
Okay.
After which other workup was done to rule out autoimmune causes, in which anti-TPO antibodies were sent, which came out to be positive to a titer of
So you did
50.
not mention autoimmune encephalitis as a differential, no?
Sorry, yeah?
With focal deficit, that becomes autoimmune encephalitis. You said about demyelination, you said about infection. So autoimmune encephalitis can come as a third differential.
You have mentioned autoimmune and you have mentioned Adam on the partner.
Second
Yes.
is, first is infection, then autoimmune. So you should, so, so you can mention autoimmune encephalitis also there.
Yes, ma'am.
Adam and the
Autoimmune differently.
Yes.
Yes. So anti-TPO antibodies were positive. ANA was negative, ESI was 54, and thyroid
In
function was.
GCMS ketonuria, in GCMS we don't get ketone like thing like ketonuria. It should be urine sugar, no, or urine ketones. Urine GCMS showed ketones to be high.
Yes, ma'am. Beta hydroxybutyrate excretion was there.
Okay.
That was their interpretation basically on the part.
That was their interpretation.
Okay.
Okay.
Why
These
have you
were the-
mentioned why have you mentioned
Go ahead.
the red?
Sorry, sir.
Why have you mentioned anti-TPO antibodies in the red?
So it was positive. And there are few case reports of Hashimoto's matlab encephalopathy,
What happened?
in which anti-TPO antibodies are positive, along with child having symptoms of psychosis and seizures.
What happens to TFT in those cases?
So TFT should be abnormal in that, but it was
Normal
not.
or abnormal?
No, abnormal in that.
Normal on the partner. Yeah, and then normally the TPOs are more higher on the partner, more than 100 in those cases.
Yeah. So it looks to be non-specific only in this
Yeah.
case.
True.
So these are the MR images.
Can you show
Once
one?
again,
Yeah.
Sorry, sir.
What is this image? T1, T2 flare.
This is
wait,
T2
you are
T2
just
image.
clicking it fast. Show the first image.
So this is the first image only.
No,
Yeah.
no. This one is the first image. Okay.
Yes.
So can you tell me the sequence of the top one? This one.
This is T2 image.
Hmm.
T2 star image in which we can see bilateral hyperintensities in the midbrain region,
Okay.
which are bilateral symmetrical hyperintensities.
And
This is normal only.
substantia nigra. Can you comment on that? In midbrain, there is a part which is substantia nigra. Okay, that is
Yes,
also,
ma'am. This area.
that is also affected.
Yes, ma'am.
And if you look at
How
the
to explain the tremors and the rigidity which the child had.
Yes, ma'am.
Okay.
So
Next.
this is T2 flare
Hmm.
image in which we can also see hyperintensities in same region as T2 image.
Hmm. Okay.
And then this is T1 image with
T1,
contrast,
T1 contrast, right?
given with contrast. And in this, we can see little hypo-intense in the same region.
No, in T1 contrast, not sure of this hypo or because it's too much hypo or it is a VR space.
to point the
Yes, this is very difficult to say that this is hypo at T1. In this next section here, I think so. Here, if my point is this one is substantia nigra looks little hypo here.
This one, huh?
Yes, this one is little hypo. But this one looks like some artifact or something.
Okay.
This one.
Next.
Then we have diffusion image in which there is no diffusion restriction in the same region.
Next.
Then we have with contrast image, coronal sections, in which we cannot see contrast enhancement in the brainstem region.
Overall, can you comment anything on meningeal enhancement, present or not present?
Not present.
It was not present. Okay. Next.
And these are the only MR images.
So it was the midbrain which was affected. No cerebellum, no cortical lesions, nothing.
No, ma'am. This was the report of the MRI brain, in which there is bilateral, almost symmetrical regions of signal abnormality and necrosis in both halves of the midbrain, particularly substantia nigra region.
How will you explain the hemiparesis in this case?
Sorry, yeah, the voice was breaking. Sorry, yeah. Your voice is breaking up.
How will you explain?
How will you express this in this? Hemiparesis.
Hemiparesis.
Shall I write it? Am I not audible?
Yeah. So Gaurav, how will you explain hemiparesis in this case?
Sir, in cerebral peduncles, because of
radiologically.
Okay.
And how will you explain altered sensorium? How will you explain altered sensorium?
Yeah. How many cells you had in the CSF?
9, sir.
They're normal, abnormal?
The borderlines are less than 6, so it's 9.
Not a borderline, na? This normal, abnormal. It's abnormal.
Normal. Yes, sir. So meningitis could be there at that time.
So you already mentioned while doing the localization part, the child had different excesses that Dr. Reddy mentioned to you, na? The encephalitis part, then the brainstem part.
Yes, sir.
Dr. Reddy, you had some questions, huh?
Yeah. I was asking, how will you explain the encephalopathy in the child with only brainstem lesion radiologically? Only midbrain affection. See, encephalopathy is mostly due to the many reasons. One is cortical affection. Here, radiologically, we cannot see that. The other thing is reticular activating system. So somewhere reticular activating system is getting affected, and that is why the child had encephalopathy. And I cannot see thalamus here, only the midbrain thing I can see. Cerebellum, I am not sure whether it was there. I think nothing was there in cerebellum, no?
Yes, ma'am. Nothing was there.
Okay. So how did you further investigations you have told? So no etiology could be picked up?
No, ma'am. This was the problem.
So how did you manage the case? I mean, how was the case managed?
Keeping it as autoimmune encephalitis. We gave IVIG to the child. That was 2 gram per kg for 5 days. Written 2 days. Sorry, I'm written at opposite. For 5 days, and after 2 days of starting IVIG, methylpred was started at 20 mg per kg, which was given for 5 days, and after which the child showed much improvement and was shifted to ward.
So will you say this as viral encephalitis, or will you say as autoimmune encephalitis, or will you say as demyelination?
Suspected autoimmune encephalitis.
In autoimmune encephalitis, okay, let us discuss how do you differentiate between infectious versus autoimmune encephalitis? Infectious encephalitis versus inflammatory or autoimmune encephalitis.
I mean, infectious, there would, in CSF studies, there would be more culture would show any growth, or in radiology also we could
Start
find.
from the history, or we start from the history. how does the encephalitis, encephalitis starts with the history versus autoimmune part?
Yes, sir. So in viral in infectious encephalitis, there would be history of fever. That
Both,
could be,
it can be there in both autoimmune also.
yes, ma'am. With both. Both will have acute presentation.
Mhm.
And in autoimmune, it could be post-infectious also. After there would be a history of prior infection, like in respiratory or any AG, gastrointestinal
Basically,
infection.
infectious are more acute and autoimmune are more subacute. Suppose this child would have presented to you at day 3 and only 3 days of illness. It presented to you at day 7 and had a
Yes,
long course. Okay, so subacute presentation or a chronic presentation goes more in the favor of autoimmune. Acute onset 1 day, 2 day history is infectious. Okay. And
yes,
other than that, any other markers if you had, suppose you had any rash, suppose you had mumps like swelling in the history that along with the fever, you had some markers for infectious etiology that goes more in the favor of infection. In
yes,
the
ma'am.
autoimmune, you might just have fever and CNS symptoms, no other markers for any infection. Okay. And then on examination, what markers will tell you that this is autoimmune or this is infection thing?
I mean, infection like we see mumps is there or any ear discharge on examination
Hmm.
or sinusitis
Hmm.
it's there or just be
Hmm.
If you have a focal
rashes there
if you have
varicella.
a focal neurological deficit in the form of hemiparesis,
Yes, ma'am.
so that goes more in the favor of infection because
Infectious
hemiparesis
cause.
encephalitis is mostly HSV. We always would like to look for HSV.
Yes,
Okay, so it goes more in any focal deficit. If you have no focal deficit, only fever, seizure, altered sensorium, more like autoimmune or inflammatory or demyelination. Okay,
yes,
so
ma'am.
here you had a history of fever, you had no rash, you had focal deficit, it goes in the favor of infection. Then what are the markers? Your imaging and CSF.
I mean, CSF, there would be pleocytosis and there would be more cells, more proteins,
Mm.
and culture would show growth of organism,
Biofire should show something.
bioshoot or some organism,
Glucose
viral
should be
organism.
high, glucose should be low. In what all organisms you expect us glucose, CSF glucose to be low,
I mean, bacterial causes CSF
right?
glucose should be in mumps. In viral cause, there could be hypoglycemia,
Hmm.
and in fungal and viral, it's almost same.
Mumps, limes, TB.
Lines, TB,
Okay, so it will be a low sugar.
bacterial causes.
That was not there in this case, so it can be a viral or it can be a uh, autoimmune. Okay, and what in MRI?
In MRI, we'll see contrast enhancement, or if the abscesses could be there, if there is focal deficits, so focal abscess could be there,
No,
and
no. Presence of any MRI abnormality will go in autoimmune or not autoimmune.
non-autoimmune causes,
That means infections. If you get a
infectious causes.
if you get any inflammatory markers, like any hyperintensities in any part of the brain, that goes more in the favor of viral encephalitis or infectious encephalitis. Or second is demyelination. Here we are discussing three things in autoimmune or inflammatory. We don't say as autoimmune, it is infection or inflammatory. In inflammatory, it is demyelination or autoimmune
Autoimmune.
intracellular or surface antibodies. Okay, in whenever you say autoimmune encephalitis, first thing is NMDR. So in
Yes,
NMDR, MRI is normal, CSF is normal most of the cases. You will get different set of features. Abnormal movements can come, but hemiparesis is little rare in NMDR. They have more of generalized features. So here your case clinically was more of viral encephalitis. Even with MRI, viral encephalitis cannot be ruled out. Either it is viral encephalitis or EDEM. Okay, we could not pick any virus, that is all right. And immunotherapy was the right choice, even with viral encephalitis. And because there was no strong evidence of any infection.
yes, sir.
Okay.
I think I think we have one question from the audiences. Who that's something, kindly send me the recording of this wonderful case discussion. I thought they've asked some question, but they want the recording on the part.
We can ask live if somebody can ask, if they want
Yeah.
to raise their hand or something.
Any questions we have? No, I think that's the
Any
part.
questions do you have, Gaurav? Did it made more clear after discussing?
Yes, ma'am. Movement disorders, I need to study more, I think. Not
No,
mentioned it properly.
I would like to give you some feedbacks. One is in history. You have done very wonderfully. Okay, so that's great. Congratulations on that.
Thank you.
The important thing is in history, I think one thing which was lacking was a little more description of whatever findings you were telling. In altered sensorium, a little more detail of, because see, I am a person who has not seen the case at all. I'm just making my own visual impressions. I was
Yes,
not
ma'am.
getting that visual impression because Dr. Praveen would have seen the case, so he would have something partial. He would not be able to point on that. I was totally a naive person for this case. So I was not able to make on altered sensorium. I was not able to make on this abnormal movements. And tone was totally gaib in your case. The tone should be
Yes,
there.
ma'am.
In raised ICP features, you just said headache and vomiting.
Vomiting.
You mentioned about hyperventilation episodes were there or not. Posturing was there or not. And if you have some idea that when the child was in hospital, was there any variability of heart rate, BP, something you could have mentioned that during the PQ course, there was no signs of raised ICP, whatever history you could get.
Yes, ma'am.
So that would make it more intricate and in details.
Yes, ma'am.
And when you write the summary can be a little more better. That summarizing after the history and summarizing after, you should practice that.
Yes, ma'am.
Add more adjectives, add more points. So like cranial nerve was absent in final, whether it was present or not present, that kind of thing. Differentials were good. And overall, it was a good experience and good kind of case. You could defend most of the things. And localization, I think so you're a bit clear on hemiparesis. He's clear on hemiparesis and extrapyramidal things. You have clear thoughts, but just presentation was a little, it can be a little better.
Sure, ma'am. You do better.
I think they fear a lot about the localization. So maybe not, because in pediatric
Lots of
neurology you'll
questions.
find, yeah. So pediatric neurology, Gaurav, you'll find that it's not like you don't have to, I mean, pinpoint. This is coming to midbrain, one is coming to pons only, basically. You're going to always have your, I mean, kind of like whole axis, because they will have a number of times they'll be involving a number of different axes, not only applying to one part, like how we see in adult neurology cases on the partner. So keep it always open. Keep it, you don't be bogged down that I have to pinpoint one location in the brain from where everything is emerging. It's most times it's not there on the partner. So Rajni will agree to that point. Fine.
Yes, yes.
So we have to be always open. I mean,
Brain, the examiner will catch you are biased. You have seen the MRI earlier. All these things will come immediately. So you have to see clinically, you have to say it is cortical affection. You have to say it is encephalopathy, can be metabolic encephalopathy, can be multiple reasons can be there. Okay. So can be because of that midbrain can be a part of reticular activating system. So you should have points, not just pointing towards midbrain. Obviously, tremors was pointing towards midbrain. But surprisingly, to my surprise also, I was not just expecting midbrain and substantia nigra. I was expecting something else also.
That's interesting. Okay. I think we are done, Gaurav, na?
Yes, sir.
Fine.
Thank you so much, ma'am. Thank you, sir.
Thanks. It was a wonderful presentation, as Dr. Rajni also mentioned. And thanks, Dr. Rajni. I think we were trying a lot to have you on the part. So
Thank you. No, it's my pleasure always. See, teaching activity is my favorite, and I always
it was
think
good
that.
to have you.
Gaurav presented it very well. It was a little complicated because at the core neurology, he presented all the parts.
And I think it was good that because he keeps on hearing from you, from us basically, it was good that he heard something from you also on the part. So that's why I wanted to have him from the others also, so they can learn from all the sources. That's the fine. So thanks a lot. Thanks a lot for joining us, and thanks a lot all the attendees for joining today. We had a good number today, and the next week also we'll be back with some other interesting case.